Innanzitutto ho il piacere di introdurre la relazione del professor Terry Derks. Il professor Terry Derks è un pediatra metabolista, professore associato all'Università di Groningen, e ci parlerà di un argomento che riteniamo molto interessante, cioè un po' l'aggiornamento relativo ai clinical trials in fase 1 e in fase 2 della terapia genica con vettore virale dei pazienti adulti affetti da glicogenosi di tipo 1A.
Thank you very much. I hope you can hear me well. I will start sharing my screen now.
Okay.
Does it work properly? Can you see my screen?
Yes, we can.
Okay. Okay, thank you. So thank you very much for the kind introduction. I also would like to thank the organizers for allowing me to present you on an update on the phase 1/2 gene therapy study results in adult GSD1A patients. And in particular, I would like to thank Nicolo for the translations. This is the first gene therapy study in humans with GSD1A. Phase 1/2 means that in this study, the sponsor and the investigators are searching for a safe dose with good effectivity in adults with GSD1A. The sponsor is the pharmaceutical company Ultragenyx, as you can see on this slide, and I'm presenting on behalf of them and on behalf of the investigators that are mentioned in this slide. So these investigators come from different metabolic centers in the United States, Canada, and in the Netherlands. I already briefly showed you this disclosure slide. These slides were done with the publicly available data provided by the team at Ultragenyx. I want to start reviewing the basic concepts of the gene therapy approach in this study. DTX401 is an adeno-associated viral vector that contains a working copy of the glucose 6 phosphatase gene. This is the gene in which people with GSD1A have their mutations. And this viral vector will go to the liver, where a working gene copy will be incorporated into the liver cells. Without being inserted in the host DNA, DTX401 will produce an active form of glucose 6 phosphatase enzyme, the enzyme the patients are deficient on. The expectation is that with this approach, the production of the glucose 6 phosphatase protein will help to treat many of the complications associated with GSD1A. Here it is important to remember that with this therapy and this approach, we are only targeting the liver and not the tissues that are also deficient on glucose 6 phosphatase, such as the kidney and the intestine. Now, most of what we know about gene therapy for GSD1A comes from extensive studies performed previously in fundamental models, such as liver cells, a mouse model, and dog models for GSD1A. In G6PC deficient mice, or in the knockout mice, a vector similar to DTX401 showed a sustained dose-dependent improvement in plasma glucose concentrations following a single intravenous injection that was similar to the improvement in the wild-type mice. So these mice were really able to fast normally. In addition, there is information from previous trials on humans on other liver diseases, and in particular from hemophilia B. In this study in humans, they use similar factors to target the liver as we are using in this study. And what do we know about these studies? Well, we knew that an important group of the population of the people will have antibodies against the viral vector, almost 30% of the population. And this will limit the amount of people that could receive this treatment. In addition, we knew that early enzyme activity could be expected, and that the viral vector will produce a transient asymptomatic liver inflammation that we need to monitor carefully and that would require treatment with steroids like prednisone. Also, because it has been more than 5 years after these trials started, we knew that we could expect a durable effect of the hemophilia treatment in some patients, and this is also very hopeful for GSD1A, of course. In the GSD1A gene therapy study, the aim is to find the effective and the safe dose of DTX401. After each cohort of 3 patients, it was decided whether the dose needed to be increased. The main outcome parameters you can see at the lower panel of this slide. These were the time to hypoglycemia during fasting, the reduction in the cornstarch dosing, and liver MRI details. I'm not going to mention the latter one, but I will give you the first insights in the fasting tolerances and the cornstarch dosings in the different patients. The next slide shows a table with the general description of the patients. Each column represents basic information about the patient. 3 patients together form a cohort with a particular dose of gene therapy. You can see for cohort 1, there is a lower dose. For cohort 2 and 3, there was a higher dose. I want to mention 3 key points. 1, there is genotype information on all the patients. Based on what we see, we could estimate how severe their disease is. And we feel that the subjects on cohort 2 and in particular cohort 3 have a more severe GSD1A phenotype. 2, there were 3 females included, patient 2, 7, and 8. 3, in addition, the last row represents the baseline information on what were the daily cornstarch prescriptions that the patients were using before they were dosed with gene therapy. Here we are seeing what happened 52 weeks after dosing with DTX401 for the subjects on cohort 1, so with the lower dose with a relatively milder GSD1A. We are seeing a sustained increase in fasting time compared to the beginning of the study that averaged 4.2 hours. Cornstarch reduction was one of the other main outcome parameters that we measured. And for the patients in cohort 1, at the end of the study, the cornstarch was significantly reduced, with complete discontinuation in 1 subject and significant reductions in the other 2 subjects. On average, for the whole cohort 1, cornstarch was reduced by 77%. What lessons have we learned from cohort 1 at the end of week 52, so after 1 year in the study? First of all, the dose was safe. Patients tolerated this 2 × 10 to the 12 per kilogram body weight well. Not all subjects in the study developed a significant liver inflammation after injection with the vector. And those that did develop this reaction usually occurred at around 6 weeks after the administration of the drug. On those who developed the hepatitis, patients 1 and 2, the use of prednisone helped to bring down the liver enzymes again. Importantly, the effect in terms of increase in fasting time and cornstarch reductions have remained and have been sustained for a longer period of time. Now let's review the cohort 2 data. These are data on week 24 that were provided by Ultragenics. Around this time, we are starting to see an increase in the time of hypoglycemia, with an average of ½ an hour for the total cohort. By week 24, we also observed a significant reduction of the cornstarch doses for all subjects in cohort 2, with an average of around 50% for the whole cohort. to put this data into context, for subject 4, who had the most significant reduction, this dose changed from 54 grams of cornstarch to 17 grams every 4 hours. Now I want to show you an interesting observation made in subject 6 at week 6. You can see on the x-axis the time of the fasting challenge, and on the y-axis you see the glucose concentrations in milligrams per deciliter. And at week 6, we have a tremendous high starting glucose concentration before the fasting challenge. And I think there are at least 2 reasons to explain her elevated glucose concentrations at that time: the early enzyme activity after the gene therapy and the prednisone she was using at that time. During this fasting challenge, we feel that the elevated glucose concentrations produced elevated insulin and a faster glucose drop, as you can see in this brown figure. And this is what we initially wanted to avoid. At week 12, she was still on prednisone, but at a lower dose, and we see a more attenuated curve. What have we learned from the experiences in cohort 2 with the higher dose? Again, that this dose was safe for all subjects in the study. The subjects had an earlier and a more significant elevation of liver enzymes that responded to higher doses of prednisone. As I mentioned in the previous slide, in one subject we observed elevated glucose concentrations that were sometimes complicating the interpretation of the fasting studies. Overall, the experiences with cohorts 1 and 2 have been very positive. 4 out of 6 patients have discontinued daily cornstarch at this point now in time, and we have also documented some weight loss in some of these subjects. Based on the experiences in cohort 1 and 2, what changes did we need to incorporate in the next cohort? Well, already in the first presentations, we heard a lot about continuous glucose monitoring. I didn't understand a lot of the Italian, but from the slide, I realized that, well, continuous glucose monitoring is a very good tool under certain circumstances, and in particular in this trial, for early anticipation when glucose concentrations were rising. So, because this enabled us to bring down the cornstarch doses. Secondly, we identified that the higher the dose, the earlier the liver enzymes elevation would occur, and the higher they would go. So for cohort 3, instead of treating with prednisone when the liver enzymes elevations occurred, we decided to incorporate a so-called optimized reactive approach and treat once we were seeing these liver enzymes increasing, even though they were still below the upper limit of normal. So this trend watching was very important because not treating the liver enzymes appropriately would mean losing some of the gene activity. Third, since we identified that the elevations of glucose will occur early in the treatment, it was necessary to monitor closely the glucose concentrations with the continuous glucose monitoring, but also to make changes in the fasting responses. So during these fasting responses, more biochemical and hormonal parameters were investigated. And this is what occurred to cohort 3 at week 12, using the same data of DTX401 as cohort 2, but incorporating the changes that I mentioned previously. By week 12, we started seeing an increase in fasting time that we did not see at this time in cohort 1 and 2. For this particular cohort, we observed lower fasting times at baseline, indicating that very probably we had a more severe group of patients. But on the other hand, you need to remember that they only had 5 grams of cornstarch at the beginning of the fasting challenge, and instead of the 35 grams that were given to the patients in cohort 1 and 2. This is a very busy slide showing graphs from the 3 patients in cohort 3, patient 7, patient 8, and patient 9 at the right panel of the slide. And in green, we see the liver enzymes increasing just a little bit in time in patient 7, with a very steep increase in patient 8 and a more moderate effect in patient 9. From these graphs, you can see that with the optimized prednisone approach in these patients, we were able to manage the liver enzyme increases rather quickly. Another important thing to see is that already at week 12, we see the significant reduction of the daily cornstarch dose, which was around 38% in cohort 1 in these brown figures. It was around 14% in cohort 2 in blue, and in cohort 3 we already see a 57% of reduction of the cornstarch doses that were given. This tells us probably that the introduction of the continuous glucose monitoring enabled us to make changes more rapidly in the cornstarch requirements and in the dietary requirements in general. So what have we learned from cohort 3 by week 12? These patients show, with the optimized reactive steroid approach, an earlier increase in hypoglycemia time duration after fasting already at 12 weeks. And we also saw that with the continuous glucose monitoring, we were able to decrease the cornstarch doses faster than in previous cohorts. Of course, we have to wait for the week 52 data to compare cohort 1, 2, and 3 more appropriately. This slide shows you a summary of the frequency of the so-called adverse effects that in general describe that the use of DTX401 was safe. It is important to report that there are no safety signals or trends noted in vital signs such as heart rate or blood pressure, physical exams, or laboratory values such as the liver chemistry or hematological data. Serious adverse events included metabolic instability and migraine, which were classified as serious due to the hospitalization, and these resolved. Both were unrelated to the drug. Overall, there were 26 possibly, probably, or definitely related adverse events in the 6 subjects, most of which were the elevations of the liver function test that resolved. As you know, cohort 3 is still ongoing, but it is very encouraging to know that 5 out of 6 subjects in cohort 1 and 2 have been enrolled in the extension study that enables us to follow up longitudinally until 5 years after dosing of the patients. We are happy to report that none of the patients during the study were affected by COVID-19. But the pandemic has certainly affected many of the research activities at the different sites and has delayed some of the fasting admissions, especially in cohort 2 and 3. What are now the main take-home messages from what we have learned up to now in this phase 1/2 study? At this time, we know that the gene therapy use with the current protocol can be safe. Even though the results are encouraging, gene therapy is still not a cure for GSD1A patients. And as you can see, a lot of work needs to be done to refine how to use gene therapy in GSD1A patients. And what are some of the questions that we hope to answer with this study? Well, we need to find out precise time and the right dosing of the prednisone in order to make sure that the transgene is captured by the liver cells and starts working properly. We will also like to know for how long will the effects of the medication work. Right now, we have almost 2 years of data in cohort 1, but the effects might remain longer based on other gene therapy studies. We do not know that for sure. And we know, based on the design of the study, about the effect on glucose control and cornstarch reductions, but what about the long-term effects in the liver and the other organs affected, like the kidneys, which is not targeted by the gene therapies? It is always important to consider what are the limitations of the study and the challenges that we have in the time. I mentioned in the introduction that around 30% of the patients carries antibodies against the viral vector. Therefore, we need to develop alternative treatment strategies for GSD1A patients who do have these antibodies. Another problem will be redosing, because once the patient receives this treatment, until now, we believe that the development of the antibodies would prevent them from being able to receive a next dose of the gene therapy with the same vector. Last, the fasting challenges that are used in this protocol, but that were also mentioned by Dr. Mundy in the previous presentation in the GLIDE study, they are very invasive and potentially dangerous. They are causing a lot of work, even though the metabolic teams, of course, are well prepared for that. But ideally, we would have an alternative approach and an alternative outcome measure that is easier to measure and ideally at home. In the preparation of this study, that was more than 5 years ago, it was discussed whether liver biopsies could be a part of the protocol. But similar as fasting challenges, liver biopsies are invasive and potentially dangerous. But at least 2 approaches deserve more attention in the future years. And these approaches are, again, continuous glucose monitoring and the use of stable isotope techniques, by which the endogenous glucose production can be measured. In theory, these methods are less invasive and could be assessed at home. In the next 2 slides, I will tell you a little bit more about the latter technique, so the use of stable isotopes. So this figure symbolizes a glucose molecule with the carbon atoms numered and with the different oxygen atoms and the protons. So the glucose concentrations are determined in our GSD patients by the amounts of uncooked cornstarch and the meals, so dietary factors, and by the deficiency in the endogenous glucose production that is depicted in the second arrow. So this is the glucose coming in the blood. Glucose that is leaving the blood compartment is used by the different cells, such as brain cells, muscles, etc. So that's what we call clearance. And the combination of these factors determines the glucose concentrations, of course. And in the first presentation, Dr. Mariana really showed nicely how CGM could play a role in the detection of the glucose concentrations in these patients. A second technique that I mentioned is the use of stable isotopes. And what do I mean by that? In a chemical way, some of the atoms in the normal glucose molecules can be replaced by atoms with a label. And this is what takes place with this stable isotope called 6,6 deuterated glucose. So at the 6th located, or at the 6th numbered carbon atoms, you see that 2 protons are replaced by a D, which is a deuterated hydrogen molecule. And after ingestion, so after drinking this stable isotope, one could measure in blood in time, so in blood spots that are also collected, for instance, for patients with phenylketonuria. And after biochemical modifications and by mass spectrometry measurements, you could calculate what is the production rate of glucose in the body, so this endogenous glucose production. And it may well be that if you measure this baseline in the GSD1A patients, showing that it is lower than in normal patients, that indeed this measure could be used longitudinally after intervention trials such as gene therapy or messenger RNA interventions. So any interventions in reality. So we have recently started a study in GSD1A patients in whom we will study as a pilot study the use of this stable isotope methodology in adult GSD1A patients. And this trial is publicly available, the information on clinicaltrials.gov. And here I really would like to acknowledge the collaboration with the center in Naples, with Professor Parenti and Dr. Rossi, and with the center in Connecticut, now led by Dr. Reba Wallman. Dr. Rossi started in October in our center, and the first patients are now being recruited for this study. And this is made possible with sponsorships by Ultragenics and by the Italian GSD Association. As a last slide, I would like to thank the collaborators in the gene therapy studies. So at the left panel, the clinical advisory board that is on board for over 5 years in supervising the study investigators and the team of Ultragenics. And at the right panel, the investigators from the different centers in the United States and in Canada. I would like to thank you for your attention, and I'm happy to answer any questions.